Hey guys, welcome back to Medical Coding with Blue. Today's episode is all about when do you query your provider in medical coding. Alright, if you're brand new to my channel, welcome. I am Blue, I'm a medical coder. I have been a medical coder for over 10 years. I really love sharing the things that I know with all of you. So I hope you'll take a second, hit that subscribe button, hit that like button, and at the end of this video helps you, I hope that you will share it. So, let's get started. Alright, I am only going to be talking about when to query a provider. Not how, okay? How needs to be on a whole separate episode because there's a lot of detail in the how to query, okay? I'm talking about when. It's important to know when because a lot of times coders get the misconception that they have to query their provider for every single infraction on their note, okay? What I'm going to talk about today covers like talking to them when to and what to look for, okay? But I will say this first, disclaimer first. If your facility has steps already, a process of when to query or ask a provider for further clarification, that's what query means. If they already have a process in place, go with the process, okay? Don't try to go against the grain. This is just what I do. And sometimes not all facilities have a process for their querying process with the providers. So I'm just putting this out there, all right? All right. The thing about querying is this. Querying is when you need to get further clarification on something, if something is not clear, if something is missing, okay? And it's very carefully selected on what is missing. We're not looking to bump the level up more. We're not looking to give them additional procedures. We are looking to see what is missing from their documentation. If there is something missing, then we need to send a query for further clarification or whatever the case may be. Now, it is all about knowing what you're looking for, all right? One of the biggest challenges that I had in the beginning when I first got into ortho was their forgetfulness on laterality, okay? That was huge. I mean, when you're in the ortho or podiatry section, podiatry was always really good, okay? But ortho was the one where I had the most trouble because they would forget or they would just say, and they would say, well, it's common sense. The thing about common sense, guys, but we can't assume anything as medical coders. We can't. That is paramount to everything that we do. We can never assume. So this is why I would tell them, I need you guys to give me laterality. I need to know what side. I need to know if you're doing an injection, what did you inject? How much did you inject? Was there a timeout called? This, the whole gamut of things, okay? Because I need all the detail that I can possibly get. When we really started stepping up our game on the injuries and the injury documentation, that's another thing as well, because even on your subsequent visits for injuries, you still need to have when did the injury occur and what caused the injury, okay? These are very important details that have to be carried through. You need to know the date of the injury. You need to know the date of the surgery because all of these things will help you to know how far along is this patient if they are in a global period. How far out from this injury are they? Okay, those are things that are very important. So it really is all about the details. But when you're looking at these documents and you're looking at them and it's just very general information, if it is codable with general information, then it is permissible to go ahead. But you really should keep in mind on those details that are missing. Because if there's something else in there that could be or that should be there to give the fuller picture of what's going on, you need to make a list, okay? Make a list, and when you are able to talk with the provider, whether it's virtual or by email, then that's when you can say, okay, well, I noticed while I was coding on your encounters that you are chronically missing this bit of information on these notes. And usually that'll call to their attention some of the things that they are missing, okay? But a lot of times when you have to, with E&M levels, if you have to go up or if you're dropping them down a level, that is another thing you can add to your list. And This list doesn't have to be given to them all at once, okay? It can be given to them in little bites just enough so that they are not overwhelmed when you're telling them that they are doing something wrong or they're doing something that's causing their levels to decrease, okay? When they're having their levels decrease, right? Or if they can't reach a certain level because missing information, right? So like, for example, when a patient is brand new and the new patient E&Ms, you know how you have to meet all of the bullets. Sometimes family history is missing. Well, if your family history is missing, you know you can't go past a level 3, right? 99203, you can't go past a level 3, no matter how good that documentation is. You can't go past a level 3 if you don't have family history, because all 3 have to be met, okay? So if you see that your provider is chronically missing that family history, that's something that you can bring up with clinical documentation improvement, okay? And this is all about making sure that there's a fuller picture here. If a patient is coming into ortho and they have like bone issues or whatever, it might be helpful to know if they have a family history of osteoporosis. Those are things that can be like helpful for the provider, because they're going to know, am I going to have to put this patient on a supplement? Am I going to have to run additional tests? Am I going to have to make sure that I put this patient through a particular program to make sure that they are going to be okay? Those are things that when you get into it and you start looking at this documentation, after a while, it won't be so much of, I need to query my providers. It's going to be, let's do some clinical documentation improvement, and you'll see a drastic drop in those queries, okay? I don't have to do too much querying anymore. Occasionally, I may have a burst of queries that I have to do with a particular provider, maybe because they're going really fast that day or whatever the case may be. But it's really few and far in between now. I've gotten most of them where it's just very rare now that I have to query. And you can get your providers to that point where you're not really having to query as much anymore. But if you're dropping levels, I don't really recommend telling the provider every single time that you've dropped a level. They can have reports run that's going to tell them if the coder change their level either up or down. They have the ability to be able to see this. And then if they want to come and question, hey, why are you dropping my levels? Then that's when you can talk to them. Well, on your new patients, maybe you're missing the family history. Maybe you're not meeting a certain number of bullets as far as like the review of systems or the physical exam, or maybe their overall history is just not as full as it should be. And this is where learning about those details is really going to help, okay? But I strongly recommend that you guys don't badger the provider for little things, okay? If you're having to drop them from a 3 to a 2, say for example, because they're coming in for a follow-up and they just happen to give themselves a 3, and it's actually the documentation comes out to a level 2, then you can say, well, that you're going to chalk that up to learning. They may select a 3 because that's what they're thinking that they need to select, but it's on you to make sure that it's coded correctly. So if you drop it down to a 2, you drop it down to a 2. Don't sit there and go back and forth with the provider. I dropped your level down to a 2. I dropped your level down to a 2, or, you know, whatever the case may be. Don't do that, because they're going to get aggravated and then they're not going to listen to you. So choose very carefully what and why you're going to this provider. Don't go to them for petty things. Okay? If it's small, go ahead and just code it out whatever you can and then move on. Only if you need it, like laterality, or there's a diagnosis that's missing, or whatever the case may be, then yes, go ahead and send a query and use your facility's querying process, okay? And like I said, we'll have to talk about how to do a good query on another episode. But with queries, you never give them the answer. You have to let them come to you with the answer. They have to be the ones to say what happened. You have to phrase it in a way where they tell you and you're not leading them, okay? You never, ever want to lead a provider, okay? So that is pretty much what it is. Be very careful. And if you're not really sure, the thing about it is you will learn after a while. It may seem like in the beginning a very daunting task. Well, doing queries and things like that, it may seem like, well, I don't really want to do that because I don't want to make the provider mad, or I don't want him to think that I don't know what I'm doing. It is all about opening those lines of communication and making sure that what they're saying in the documentation is clear, okay? That has to be above all else. It has to be clear. And if they are dropping levels, they're dropping levels. If they're going up in levels, that's something you can also note too, so that when you do meet with them, you can say, well, you did really good because I was able to elevate the level from a 3 to a 4, or from a 4 possibly to a 5 because of X, Y, and Z, okay? They need to know those details as to why. But looking for those, like the stages of a pressure ulcer, that is often missing. I talked about that on another episode. Stages of pressure ulcers missing. Stages of chronic kidney disease is also missing. Oftentimes, that's one of those things that that's just that one little detail thing, you know. And there's lots of other disease processes that have different levels. So when you are coding for a clinic that has diseases at different levels, like CKD or I think macular degeneration is another one, but they have different levels, then you know that you need to be looking for those little details in there. And if they're not there, then that's when you can talk with your provider about that. Other things like Alzheimer's, that's another one, to make sure that they're saying if they have a behavioral disturbance or not. That's another one, because that is one of those ones that it goes together with those codes. You have to be able to have that information, and you don't want to always have to query those things back. And we are often told, do not use unspecified diagnoses. And it's true. We should not be using unspecified diagnoses. Very rarely or never should we be using unspecified diagnoses, because the patient had the condition on something, you know, and it was either left or right, you know. So we want to make sure that all of those details are always going to be there. And like I said, work with your provider. If this is a chronic error that they are making, perhaps you can work with them to build a template that would help them to just be able to fill in information. Different electronic health record systems have different ways of creating templates. Epic is really good for those. I know Alta is really good for that as well. So there's just a bunch of different ways that they can do it, but you have to be proactive and work with your provider when you see these things, because the more elbow grease you put into working out those kinks within the documentation to make sure that it is clear, the better and the easier and the faster you'll be able to get through all the documentation, because you've done the work. You've put in the time with the provider to make sure that they know all of the information that they need to document. Okay. And the same thing with the chronic conditions. If they have a history of a chronic condition, this is something that they need to make sure that they're very clear on. History means they no longer have it. That's how we as medical coders are seeing it. But oftentimes you'll see in the documentation that the provider will say the patient has a history of hypertension, chronic kidney disease, and diabetes. Does this mean that the patient still has it? Are they actively having it? Obviously, we think yes, they would, you know. But we need to make sure that the provider understands when they're documenting that the patient has these chronic diseases or chronic conditions, they just need to be direct to the point. Diabetes, hypertension, chronic kidney disease, those kinds of things. Hyperlipidemia. If they don't have the hyperlipidemia anymore, they can put history of hyperlipidemia. If they don't smoke anymore, they can say history of tobacco use, quit in 1995 or quit in 2005, whatever the case may be. So whenever that's something that I'm still working with my providers on that, because I tell them history means it's no more. They go, well, it just means history, like they still have it. And I'm like, see, there's a difference between coders and providers. This is how we are seeing this information. so that there is no confusion. You always want to make sure that everything is clear, okay? If they have a chronic condition, I always tell them, just put the chronic condition, you know, and if it's pertinent, it's pertinent. Like if you're monitoring it, if it's stable, if it's going to impact their care, and then if they're on medications, that kind of thing. It's very important to have all the information in there, okay? But take things one step at a time with these providers. You can't just come at them, you know, full throttle, okay? You got to take things slow because they will shut down after the first 3 things. Okay, this is what I always recommend. If you're going to go to them with only 3 things. Because when you start doing 4 and 5 things, that's when their attention span just goes away. You've got a good 10 minutes of their attention span. And that's being generous. So just make sure that when you're going to them, you're not overloading them. And if you say, well, Blue, I've got a bunch of issues with them, then just pick the first 3 things that you can think of that are most pertinent to helping this provider to improve their documentation. What is it? Then you can work on the next 3. Once they're doing good with those first 3, then you can move on to the next 3. And then so on and so forth. But the major point being, don't overwhelm them, okay? And if you're writing them an email, like to remind them about something or whatever the case may be, make sure that it is to the point. If you are writing an email and it's 3 paragraphs long because you're telling them all these things that they need, cut it down to 1 paragraph. It needs to be to the point with just as much information as is possibly needed, and then that's it. Okay? So that is something that you have to work on that. You have to work on, you know, the minimum amount of words that you can possibly get away with while still making sense and while still being able to get your point across. Okay? So that way they know. They want the bullet points. I have to bring Dr. X into this because I've learned a lot from him. But we were in a meeting with a Dr. X. If you guys don't know, he is a provider that I work with, and he's very instrumental in my growth as a medical coder. It all started with him. It always starts with one provider, right? So Dr. X, we were all in a meeting, and we were in this meeting with a person who is called a physician champion, okay? Now, this physician champion was there at the start of ICD-10, okay? So it was we were about a year into ICD-10, and we were still trying to get everybody to get on board, and he was brought in to help all of the clinics to discuss the fine points of ICD-10 coding. And so they invited the one coder per clinic to come in and sit while, that we listened. So out of me and my partner at the time, I was picked to go with ortho, which was fine. So he's up there and he's talking, and he's a very eloquent speaker, this physician champion, and he gave out an awesome packet. I mean, I really love this provider too, because he is so awesome. Unfortunately, he is not with our hospital system anymore, which makes me very sad, but it's okay. I'm sure he's making some coder's day out there somewhere. But he wrote a very nice paper, and he wrote all these fine details and everything. And Dr. X happened to be sitting cat-a-corner to me during this meeting, and I was sitting over with the ortho spine surgeon and one of the sports medicine doctors, and we were sitting there talking, and we were on a break, and so we were all sitting there talking, and they're trying to get clarification, and then all of a sudden I hear Dr. X tell me, "Blue," and I just look over, I'm like, "Excuse me?" And he's like, "Do you see this? Do you see this packet?" I'm like, "Yeah, it's pretty awesome." He goes, "I don't want this. I want 1 page. Everything that's in here, I want it on 1 page." I go, "You got it." And so everybody's just kind of like looking at me. What he said that he needed was bullet points. He didn't want all this wording. He didn't want all this drawn out language. He just wanted 1 page, basically to the point. So I said, "Yeah, I can do that for you." And he's like, "Okay." And then he went about doing his own thing. So this is something that when providers get to know you and they know that they can ask you for help, they know that they can get the information that they need right away. That is a mark of a good relationship, okay? Because that's going to help that provider. And sure enough, it did. So I did all the bullet points. I did all of that. Everything looked really good. And, you know, and I gave it to him. He was like, this is absolutely what I wanted. He goes, I can't with this. This is too much. I said, I know. I got you. Don't worry. And then, of course, I had another provider that was in the room with him can I get a copy? So I gave him a copy, and I made sure that I gave out copies for everybody else as well. But it was what they needed. And so, again, that goes back to learning your provider and learning what it is that what would be best to help them, and especially in those situations. Because when you start telling a provider how to document better, they're either going to go one of two ways. They're either going to get aggravated because they know more, or they're going to be like, okay, I just need to get on board with you because I don't know what it is that you are saying that you need. And I want to make sure that I'm getting paid for all of my work. And that's what it boils down to. So having that detail and doing that clinical documentation improvement is going to lessen the amount of queries that you're going to have to perform. And if you're doing it right, the amount of queries that you're going to have to perform is going to be very low. Okay, so again, it's going to go back to if a provider's just having an off day. But that's it. That's the long and short of it. So I hope this helped. But yes, don't think you have to query your provider for every little thing. Don't get after them for little things. If they're missing something or whatever, or if they're picking up a higher level, I don't necessarily get after them always for that. The only time that I kind of look at them kind of funny is when they code themselves too low, especially on the evaluation and management levels. Dr. X was having this issue. He kept giving himself a lower level, and I'm like, why are you doing that? That's not like you. That's not normal. He's like, well, I thought I couldn't get higher. And I'm like, do we need to have another class? Because you're doing really good and you're meeting the bullets for a higher level. So it's just a matter of just getting them recalibrated and making sure that everybody's on the same page. So sometimes you just have to do what you have to do, and you have to talk to them. And that's the most important thing. So when you're getting those good relationships going, again, that's going to help the amount of queries that you're going to have to go down. Okay, so, but don't be afraid, whatever you do. Building relationships with providers is really important. And I think a lot of coders don't think about that. And sometimes it's out of their control. They may have a situation where it's only one person that talks to the providers, which I like and I don't like at the same time. If it's one person that's talking to the providers, hopefully it is the active coder for that clinic, because nobody's going to know that documentation better than that coder. Okay, because they can be telling the clinical documentation improvement person one story, but then the coder who's actively coding it will see another story. So that's why I always say it's got to be with the coder. You know, it can't really be with anybody else. And sometimes if it is with somebody else and they really are very astute with their job, then yeah, then you got a good thing going. But it all depends. So like I said, follow your facility's guidelines. I'm just offering advice on that, on what I do. So like I said, I just try to keep it as low stress as possible. I'm not going to sit there and nag them for things that are trivial. Okay, I'm going to get them for things that make sense and impact them down the line. Okay, so that's my episode for today. So I hope you'll join me tomorrow, and I will go ahead and wrap this one up. So if you are a medical coder, a medical coding student, somebody curious about the fascinating world of medical coding, a provider or a nurse, I invite you to like and subscribe and follow me on my journey in medical coding. I will see you all next time. Bye.